Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins, a family medicine physician and senior physician advisor here at the AMA. Inefficient workflows, excessive EHR documentation, overinterpreted regulatory requirements, critical time pressure, overwhelming cognitive load, and lots of other administrative burdens have come between physicians and our patients. There's just too many low-value and no-value task work obstacles that negatively impact physician professional satisfaction and quality patient care. Team-based care, a collaborative system in which the responsibility for task work necessary to deliver safe, high-quality care to our patients is shared across engaged, well-trained, and qualified team members, and this allows physicians to remain focused on what matters most, our relationships with our patients. Today, we're talking about the impact of team-based ordering workflows. I'm joined by Dr. Nate Apathy. Nate has a PhD in health policy and management with a concentration in health informatics and is an assistant professor of health policy and management at the University of Maryland School of Public Health in College Park, Maryland. He's also an affiliated research scientist at the Regan Streif Institute in Indianapolis, Indiana. Thanks for being on the podcast today, Nate.
Thanks for having me.
You bet. So before we get into our topic for the day, would you mind telling us a little bit more about yourself and your background than what I was able to share in the intro?
Sure. So as you noted, I'm an assistant professor at the University of Maryland. I broadly study how technology can be used in healthcare to improve the quality of care, including what you kind of introduced in the intro of around clinician well-being and high-functioning teams. A lot of my work over the last few years has focused on documentation and other administrative burdens, and those that are brokered primarily through the electronic health record, given my background in health informatics. I actually started out working at Cerner, which is now Oracle Health, implementing systems across the country during kind of the major era of the High Tech Act between 2011 and 2016. And then I went to get my PhD at Indiana University and did a postdoc after that, and then spent some time working in a health system here in DC, MedStar Health, for about a year and a half to really get the vantage point from within the system on what was burdening providers and what organizations could do to actually alleviate some of those burdens.
All right, fantastic. Thanks for sharing that. Could you speak a little bit about maybe what got you interested in studying as a researcher team-based ordering workflows? I mean, it's a pretty specific topic, and certainly a topic that our AMA Steps Forward team has a high level of interest in. We have toolkits and things that talk about team-based care and ordering workflows. But what got you interested in studying it?
Yeah, there's a couple of things. First off, I'm broadly interested in how teams are constructed and how they actually take shape in clinical practice, and if there are ways to build teams and maintain teams and operate teams that are more efficient than other ways, to understand how we can build kind of the optimal care team for a given practice environment or even a given individual physician. And so team-based ordering workflows I see as kind of a component of that, or a measurable element of teamwork. It's very, very difficult to measure teamwork in practice. And so teamwork for ordering is a nice way to really empirically identify that people are sharing the load here. I've done related work around shared documentation. This work came out earlier this year in JAMA Internal Medicine, looking at when physicians go from not having any documentation support, so no one else is writing anything in their note, to having other people write components of their notes. We wanted to see what happens to their documentation time. This coming from the fact that documentation time is the plurality of time that physicians spend in the EHR, and what we can do to reduce that burden is important, and we want to find out what those things are. And one of the things that we found in that study is that how much of the documentation that the other team members are doing matters a lot in terms of your time savings. And if you don't have the other members of the team authoring 40+% of the note, you're actually not going to save yourself any time on documentation. There's no after hours time savings. There's no savings on any other element of time in the EHR, which is not what you would hope for in terms of a sort of first order impact of shared documentation. And so that really speaks to this idea that organizational adaptation of these team based interventions and sort of team based models matters a lot. And we want to understand what are the ways that organizations can implement these team based models in ways that are going to be reliably successful. And so this was just kind of an extension of that work, really thinking about what are the other areas in which we can collaborate. And orders, kind of unlike documentation, are a place where there's a lot clearer lines around what can be offloaded and what can be delegated, and the roles are a little bit easier to define and a little bit less kind of up to the personal preferences of an individual clinician. There's definitely still that personal preference there. But we were curious about, do we see a similar relationship here when we start sharing things, when we start sharing ordering practices, what happens to people's time spent in orders?
All right, so I can already tell I'm going to love this conversation because these are topics that I'm really passionate about, and our AMA Steps Forward team certainly is. Anything we can do to help decrease the amount of time that physicians particularly spend looking at a digital screen, clicking a mouse, tapping a keyboard will enable them to be, like I said earlier, focused on what matters most, our relationships with our patients, and actually delivering care in a way and at a level that physicians are uniquely trained and qualified to do, that nobody else on the team can do. And I think sometimes physicians have been hesitant to delegate responsibility for other tasks because they don't know who can do what. And also, honestly, because we're a little bit of control minded and tend to not like to give up control. And yet we know that we need help. There's literally more work to do than time available for it to be done. And no one person can be as effective as a team, certainly. So sounds like in this research specifically that we're going to discuss today, you were looking at time spent on orders, on order entry, and what percentage of those orders were entered by somebody other than the physician. Is that right?
That's correct.
Okay, great. What did you think you would find?
So we were curious about this sort of first order effect that we care about with team-based ordering, which is when you implement a team-based ordering strategy, and that you should be saving time for the focal physician on ordering. That is kind of the most direct first order effect that we would expect to see. And while that may sound obvious, and almost so obvious that you don't even need to study it, our findings around the implementation of shared documentation kind of raised our spidey senses around this, where actually it's not immediately clear that that any amount of shared ordering is going to save time on orders. That first order benefit isn't necessarily going to accrue if the team-based strategy isn't implemented in the right way or enough or to a certain extent or consistently over time or something like that.
This is one of the limitations that we have in improving the relative value of practice transformation efforts, is showing what is the potential impact. And health systems and health system leaders always want to know from us, what can we do or put in place or change that's actually going to have a significant impact in time savings? So to be able to quantify that sounds really, really powerful.
Yeah, and to be able to describe what that teamwork actually looks like empirically, like in a way that you can then implement in practice, right? You can imagine implementing a team-based ordering workflow and saying, going back to the practice a month later and saying, hey, are you guys doing team-based ordering? And them saying yes, and then looking at the time in orders and it hasn't changed. That's very different from going to that practice and saying, hey, I see that you guys are only sharing about 10% of these orders. why is it that only 10% of the orders are getting pended by someone else on the care team? Do you think there's a way for you to build a workflow to get you up to 60% or 70%? What are the barriers to getting that number higher? And that's a real concrete organizational intervention that someone can go take action on, as opposed to yes, no, we are or are not implementing orders and implementing team-based orders with very little detail around how that implementation is actually taking place in practice.
Yeah, and what that means, like saying, are you doing pre-visit planning? Yeah. Okay, but that means different things to different people, right? This seems like a more concrete idea, and it's something that we measure when we work with health systems around assessment with the AMA organizational biopsy. It's one of the things that we ask in the Joy in Medicine recognition program as far as thinking about teamwork in orders. So that's why it's such a great topic for us.
Yeah.
So what'd you find out? And what do the findings suggest about the impact of team-based ordering workflows? Does it make a difference?
So the high-level findings are that high rates of team-based ordering, which is measured as kind of the proportion, what I suggested earlier, with the proportion of orders that someone else set up for the physician, the higher that number is, the more time savings you have on your ordering. And to give you kind of a precise number on that, if a physician goes from somewhere between 0 and 25% of their orders being pended by another team member, up to between 75 and 100% of their orders being pended, they can expect to save, on average, around 23% of their ordering time. So almost cutting their ordering time by a quarter, which is a huge relative change for that kind of an intervention. And in kind of real terms, in terms of actual minutes terms, that's only about 11 minutes per 8 patient scheduled hours, but that's 11 of 50 total. And so that's a big relative chunk to cut out of that ordering time. And that's time that you can then spend talking to patients directly, not doing EHR-based tasks, or if you have a preference around going and looking at the health information exchange system or going and doing a more thorough chart review or making another call to a potential referral. And these are all things that we think are more important for care quality than making sure that you've selected the right dose from the drop-down list in the ordering workflow.
So 50 minutes per 8-hour day, that sounds like a lot of time spent on order entry, task-based work by a physician that for sure could be delegated to someone else. Is there a wide range among physicians in the amount of time that we spend putting orders into an EHR system?
Yeah, in general, we see with a lot of these EHR-based measures in terms of how much time you spend in different parts of the EHR and overall, there is a lot of physician-level variation. In particular, for orders, we see that there's sort of just shy of 50 minutes as kind of the standard deviation of that measure, 50 minutes per 8 patient scheduled hours, which suggests a pretty wide swath of ordering time, which then, right, the average savings is about 23%. But if you're going from 0 to 25% of your orders with team contributions up to 100%, so not 75 to 100, but up to 100, that's a nearly 30% time savings. There's a real clear kind of dose response effect here, where as you kind of start climbing the teamwork ladder, you end up saving more and more time. And obviously, for those physicians that are at the higher end of ordering time, you have a lot more time to kind of claw back. And so there's a higher potential kind of absolute time savings for those clinicians, but it's a lower relative time savings. It can be sometimes hard to keep all these numbers straight and make them comparable, but that's just to call out that there are physicians that are spending, an hour and a half on ordering per 8 scheduled patient hours. And if they can save 30 to 50% on their ordering time, that's a far bigger cut and a much larger kind of return of time to them.
Sure. Yes. Even a smaller percent of a bigger number is still a significant number, right?
Exactly.
Were there a lot of physicians that you studied for this, or was this like a small n size at one practice?
Yeah, so this is a very large sample. We have a national sample of data from US based Epic using physicians. So these are physicians that use the Epic system for their ambulatory care. I should say this is ambulatory only. This is not, there's no inpatient doctors here. We ended up with about 250,000 physicians across 400 different organizations, kind of in our final analysis. And this is looking at these 250,000 physicians over, on average, about 3 years, where we can see in every month how much of your ordering was being done with sort of teamwork, right? How many orders or what proportion of your orders were being pended by another team member.
That sounds like a whole lot of data. I mean, that must give you pretty strong confidence that the results are. I don't know what's the word I want to use here.
Generalizable is generally what we go for.
Yeah, that the results are generalizable.
Yeah, and that's really one of the challenges with studying any of these things in practice in a single site is that you generally are not going to have the kind of power to your statistical analysis that you need in order to draw kind of precise and generalizable conclusions. Our sort of confidence intervals on these estimates are very, very tight because we have so many people and we're averaging over such a big population, we can sort of more plausibly say that this is representative of the average US ambulatory physician, certainly an ambulatory physician using the Epic system, which is a huge number of ambulatory physicians in the United States.
Anytime that you spend less time on one task, in my experience, often that physician time just gets spent on something else, whether it's documentation time or, something else in the EHR. It doesn't mean I'm leaving the office 11 minutes earlier at night. Did you find that to be true?
We had some different ideas around the direction that this could take. It could be to your point that this time gets kind of reallocated into other EHR based tasks. It also could get reallocated into non-EHR based tasks, or it could get reallocated into actual quality of life time savings type things, like your example of going home, which I don't know. But what we found is really major spillover effects on other dimensions of EHR usage. So, for example, the time that physicians spent on their notes went down 15% as well. The amount of time that they spent on chart review went down. The amount of time they spent on their inbox went down. The amount of time that they spent on work outside of work, which is kind of comprehensive of all the EHR work that you might do outside of your clinic hours, went down substantially. And those are kind of major spillover effects of this kind of teamwork model, we think. And our kind of hypothesis here is that this measure of how many orders did someone else pen for you is actually a broader measure of how much teamwork is actually happening in your practice and can kind of proxy this broader concept of teamwork in ambulatory care because we see such clear time savings across the board in all of these dimensions that plausibly are kind of not necessarily directly related to ordering. It's not necessarily obvious at the outset that your documentation time should also go down. Maybe you spend more time documenting because now now you have those 11 minutes back and you reallocate it into your documentation or you reallocate it into your chart review or looking at a health information exchange system. That's entirely possible as well, but we don't see that happening at all.
Wow, that's really interesting because yeah, like I said, that's what I would have assumed is that time just gets taken up by something else. But I guess it does also make sense. I practiced in a team-based care model with the same two really high functioning medical assistants for over a decade, and we started with in-room documentation support where they helped collect the history of present illness and document that in the note for the visit for the encounter for the day. and then they would come out, present to me much like a medical student or resident would. And then they'd go back in the exam room with me when I come in to see the patient. They'd sit at the computer and kind of act as scribe. And once they really got good at doing that, they started to ask, like, well, do you want us to start pending orders for you? And I was like, yes, absolutely. I'd love for you to do that. And, they would often know what I was going to do before it even came out of my mouth because, one, I'm a creature of habit. Two, I'm fairly predictable as a result of that. And so they would already have, medicines pended that they knew I was going to prescribe, or imaging studies or consults or referrals, because it was part of the conversation taking place in real time with the patient. We found that to be a really effective and efficient workflow. So I guess on one hand, it's kind of surprising, but on the other, maybe it's not.
Yeah, I mean, there's two things you said there that I want to expand on. One is this idea that there's the co-occurrence of team-based work practices, and that's very common. And that's something that we really want to investigate kind of as we extend this work is where are those like complementarities with shared documentation and shared teamwork for ordering and maybe like inbox pooling, right? Where you see the kind of the co-occurrence and, big gains that can be made because there's multiple team-based strategies going on in the same practice. That's something that I think is highly salient to operational folks who are thinking about how do I implement a team-based strategy or team-based practice in these practices that I run. What does it need to look like, and what are the things that complement each other, and what are the things that enhance each other, and what are the things that don't, and sort of what does that collaboration really look like? And the second thing is around your comment around being kind of a creature of habit and having kind of your own practices. We talked earlier about how there's lots and lots of physician level variation in these measures. It's really important to note that that variation is across physicians. And if you look at the same physician over time, they're actually quite consistent. And folks don't actually change their practices all that often. And they're consistent even if they're kind of like chaotic. Like I've looked at charts of kind of when people are using the EHR throughout the day, the 24-hour period, and people who like use it all over the place consistently use it all over the place. Right? And people
Yes.
who take a lunch break consistently take a lunch break. And people who are done at 3 consistently are done at 3. And people who start at 5 a.m. consistently start at 5 a.m. And so while there's this immense variation across physicians, within physicians over time, it's actually a lot more stable, which I think is an interesting thing for both researchers to think about in terms of what does it mean when a physician really changes their practice? That's a major change, right? And then also, what does that mean for practice managers who are trying to get creatures of habit to develop new habits?
Yes, new, better habits that serve ourselves and the team and our patients better.
Yeah,
It's really interesting to hear you say that. Like, so much of the practice of medicine is, especially around diagnostics, is pattern recognition. Like, oh, I've seen this before. And for you as a researcher looking at patterns, there's pattern recognition there, and you can see where there can be efficiency gained. I want to talk about how you implement a team-based workflow for orders. But before we do that, I just want to ask you, is there anything else that you learned as a result of this study that surprised you?
I think the main thing that I would also mention that we haven't brought up yet is that we also looked at visit volume as an outcome here. And we see increases in visit volume as well, on the order of about 4.5, 4-ish% more visits per week. And when you can, this was something that we also found in our shared documentation study, which was these interventions and these team-based models of care can both save you administrative time in the EHR and increase your visit volume. And I think in a prescriptive sense, saying like, we heard from a lot of physicians that around the documentation study that, oh, yeah, in my practice, it's a condition of getting a scribe that you have to commit to higher volume. I don't know that that's the right prescription.
I can say almost definitively that it's not, because I've seen it. If it's a condition for participation, people will opt out. But if you just let it happen organically, it often does.
Exactly. And so I think, and we put in that paper some kind of notes around, we really need to proceed with caution before we implement these with the goal, the explicit goal or requirement of increasing visit volume, because what we're trying to do is increase the quality of each visit, not necessarily increase the volume of visits overall. But even without that as an explicit goal, we do see this increase in visit volume, which I think lends even more kind of operational support to some of these interventions where it's actually less administratively burdensome and you're able to see more patients.
Yeah, certainly. As you were saying that, Nate, I was thinking, wow, if I'm a physician working in a productivity based model, one that gets my attention because more efficiency and being able to take care of more patients is appealing. Two, if I'm an administrative leader or practice administrator or practice manager at a medical practice, it's going to be appealing to me too. Like just seeing the trends that you listed off, certainly time spent on orders being decreased, time spent in note documentation being decreased, time spent in chart review decreased, work outside of work being decreased, inbox time decreased, and increases in visit volume. I mean, that sounds really attractive in a lot of ways.
Yeah, and I should say too, just descriptively looking at average rates of this across the physician population, is one of the limitations here is like if everybody's already at 90%, there's not a lot of room to improve, but that's not the case. The average primary care physician is only doing about 20 to 25% of their orders with any type of teamwork. And that implies to us that there's lots and lots of room for improvement here. And there's lots and lots of time savings and lots of potential benefits that are still sort of yet to be realized in the healthcare system, just around teamwork for ordering.
So just hearing a little over 4%, 4.5% increase in visits per week, visit volume. So, maybe a percent, percent and a half per week.
Yeah, and so when we look at visit volume, we see about a 1.5 visit per week increase. That's that 4% number that I mentioned earlier. And just thinking about extrapolating that within this study, that's, 300,000 plus new visits over the course of this 3-year period that are sort of at least in part attributable to shared ordering practices within this sample of physicians. And so, more than 100,000 new-ish visits that wouldn't have happened otherwise every year of this 3-year study, that's a really substantial gain in terms of supply and access and availability of visits for patients.
Yes, I was thinking about the same thing, and I literally could not have said it better myself, Nate. So thank you for articulating that. And that could go, a long ways towards helping some of the limitations that we have around access and our patients being able to see us when they want and need to be seen. So I want to pivot a little bit and ask you, what does a realistic team-based workflow for order entry look like? Obviously, practices and systems that do this probably have some variation in what their workflow is like, but could you describe for us what that might be like at its most basic level?
Sure, and it sounds like you yourself have some experience with this too, so you can check my work here. But really, all of this and what we're focusing on here hinges on what's frequently referred to in the electronic health record as "quote unquote" pending orders. And so, what this means in practice, and I'll tell this kind of from the perspective of a patient, you might come into a clinic for a scheduled appointment. You're going to go through the registration process. Let's say you get roomed by a medical assistant or an RN. You have a couple conversations. Maybe you do maybe a screener or something like that. And let's say that screener suggests that you might benefit from a referral to, let's use behavioral health as an example. you might want a referral to behavioral health. That, in a sort of non-teamwork based sort of ordering model, that information then has to get passed on to the physician for then the physician to go in and place that referral order. In a teamwork for ordering workflow, the person who's doing that screener in that moment can go into the electronic health records, open up the ordering module, set up that order for that referral, and basically leave it in all but the last step. Get everything but the last step of signing that order done. And then when the physician comes in later and you have a conversation maybe about the main thing that you came in for, the physician then looks at the pended orders list and says, "Oh, I see that there's like a referral here for behavioral health. There's also a medication refill that, you've been on this medication for a while, so we'll go ahead and refill that. No problem." All they have to then do is click sign. And so it removes the kind of administrative part of the ordering from the physician's workflow, and it shifts their kind of cognitive work to the sort of clinical reasoning part of the ordering workflow, which is this something that I think this patient really needs? Another example could be that, let's say the patient is complaining about some mild back pain, and an MA puts in an order for, imaging for that lower back pain. The physician might see that and say, actually, let's try something else first. Let's try a referral to physical therapy. Let's not actually do that imaging for low back pain, because we know from the Choosing Wisely guidelines that that's maybe not the best path for you right now. And so that's the part of that workflow that we actually really want the clinician's clinical reasoning on. And so this ability to pend these orders allows the clinician to do that clinical reasoning, or allows the physician to do that kind of clinical reasoning and evaluation and sign off, and not have to do the administrative piece, like what I mentioned earlier, of like making sure that you're going through the pick list in the right order and clicking this and clicking down to this other order and making sure that it's the right, the right particular medication, to make sure that all of those boxes are checked, because that's something that are very much doable by the care team at a high level of quality.
Yeah, great examples. If a physician or if a practice wanted to implement team-based workflows for ordering, where would you recommend that they start? And are there specific barriers or obstacles maybe they should anticipate?
Sure. So I'm an empiricist, and so I tend to take an empirical approach to these types of questions, which is, number one, I would look at your ordering practices historically and see what are the most common orders that we are placing for patients on a regular basis. And can any of those be delegated? Can the process for placing or pending the orders that we place most frequently be something that I can empower the staff to do the pending of? Because those are going to be your highest yield in terms of the proportion, right? If you want to get your proportion of orders with teamwork, you start with the ones that you do the most. And so that's one place that I would start. I would also start by just taking a step back and looking at your overall care process kind of workflows for a single patient kind of flowing through their clinic visit, and look for opportunities where there's time and availability and the right person to start that pending order task. If there's no conversation happening during the rooming process, for example, it's going to be very difficult to implement a team-based ordering strategy during that moment. But if that conversation, or if there's some sort of data collection that's actually happening during the registration process, it's actually possible that you could even collect some information from the patient while they're waiting. That information then gets presented to the registration clerk, who can then even potentially pen some orders. So there's different places where this can fit in depending on your clinic's workflow. And so I would do those two things. That's where I would start. I would look at high volume orders to see which ones we can delegate. And then I would look at basically what to delegate and when to delegate it. And identify those points in the process where you can actually do that delegation and implement that workflow for the staff.
I think that's a great idea, that you don't have to take on everything all at once. Start with the things that make sense. Make sure you ensure some success. Have quick wins in low risk situations, for example. And I think that could be very effective. In some of our practices that we've done it in, we started with things from the health maintenance tool, like some immunization orders, screening mammogram orders, lipid panels screening for high cholesterol, or blood sugar screening for diabetes. Certainly that can be a logical place to start too. And I guess I'll say, from a practical standpoint, things you should anticipate, barriers and obstacles, is conversations around, well, boy, we already don't have enough medical assistants or nurses, and they already have more work to do than they can do as well. So thinking about what can we de-implement, so thinking about the AMA de-implementation checklist, that maybe it's work that our clinical support team is doing now that isn't as vital or as important or even necessary. It doesn't add as much value to the patient experience and outcome and organization support as something like this. And then being prepared to have conversations around scope of work. Anybody can pen orders in the EHR. The regulatory guidelines are very clear about that. We have a debunking regulatory myths topic about that people can check out. But those are a couple of specific barriers that I would recommend people think about in advance. Yeah, we covered a lot of ground, and I think our listeners will find it very valuable and very useful. Some steps forward references and resources that I would call out that include topics around assisted order entry or teamwork for order entry, include the Saving Time Playbook from Steps Forward, the Steps Forward Team-Based Care Toolkit, and Team Documentation Toolkit are things I would definitely recommend folks check out. Our guest has been Dr. Nate Apathy, Assistant Professor of Health Policy and Management at the University of Maryland School of Public Health and Affiliated Research Scientist at the Regan Streif Institute in Indianapolis, Indiana. Please check out the episode description to explore the resources that we've mentioned in today's episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.